Hello, today we'll be discussing the lower limb anatomy. This is MRCS strategies. And like I said in the upper limb video, that the lower limb and upper limb are frequent features in the MRCS Part B OSCE, and it's important for you to acquaint yourself with them. So this is a guide to understanding the anatomy of the lower limb. We will start from the hip. And the femur. So it's important to be able to identify the following structures on the femur bone: the head of the femur, okay, the head of the femur, the head of the femur, the greater trochanter, the lesser trochanter, the intertrochanteric crest, okay, the intertrochanteric crest, the fovea, and the trochanteric fossa, okay, and the trochanteric fossa, and the quadrate tubercle, all right, and the quadrate tubercle, which will be somewhere here, okay. So it's important to be able to identify those structures. Of course, it's also important to know what are the muscular attachments to these bony structures. So that again is also important to know. And we said that the trochanteric fossa, so the trochanteric fossa houses the insertion of the lateral rotators of the hip joint, okay, houses the insertion of the lateral rotators of the hip joints, which are, so the trochanteric fossa houses the lateral rotators, of the hip, okay, and this will be piriformis, gamellae, which include the superior gamellae and the inferior gamellae, the quadratus femoris, which we insert into the quadrate tubercle, and the obturator internus and externus. To the greater trochanter, the gluteus medius and minimus sets here, and again to the lesser trochanter, the iliopsoas sets at the lesser trochanter. Okay, now having said that, we will turn our attention now to the blood supply We'll turn our attention now to the blood supply of the head of the femur. So the blood supply to the head of the femur arises from the common femoral artery, which divides into the profunda femoris and superficial femoral artery. The arising from the profunda femoris are the circumflex artery, and there is the medial circumflex artery and the lateral circumflex artery. The main supply comes from the medial circumflex artery, which runs posteriorly, and the lateral circumflex artery supplies from the anterior aspect of the neck / head of the femur. These vessels pass through the retinacular ligaments and the interosseous ligaments to reach the head of the femur. In cases where there is fracture of the neck of the femur, okay, especially with intracapsular fractures, there is loss of the blood supply to the head of the femur is cut off, and this disrupts the retinacular arteries and lead to loss of blood supply, which leads to bone death, which is also called osteonecrosis of the head of femur, and or avascular necrosis of the head of femur. And of course, for patients who come down with this type of injury, they will require, some of them will require surgery. Of course, this is dependent on what the age group is, what type of fracture it is, and the benefits, the risk versus the benefits of doing surgery. Again, the stability of the hip joint is dependent on three factors: the depth of the acetabulum, the acetabular labrum, and the ligamentum teres. Again, we said that fractures of the neck of the femur could either be intracapsular or extracapsular. With intracapsular fracture, most of the time patients will require an arthroplasty, and for extracapsular fracture, they will require internal fixation with dynamic hip screw or intramedullary nailing. Intramedullary nailing is the choice for patients who have peritrochanteric fracture or subtrochanteric fracture. Okay, you offer them intramedullary nailing. The Guardian's classification provides a good way to view and classify femoral fracture. This is a radiologic classification that has clinical or management applications. So it divided into type 1, type 2, type 3, and type 4 fractures. The type 1 fractures essentially are stable fractures with valgus impaction. The type 2 fractures are typically complete fractures, okay, but they are undisplaced. The type 3 fractures, okay, are displaced fracture, but there is still end-to-end bone contact, okay? Displaced fracture, so something, almost something like that, okay? So it's displaced fracture, okay? So it's displaced fracture, but there is still end-to-end bone contact. And the type 4 fractures are displaced fractures without contact of the bony fragments. Of course, with type 1 and type 2 fractures, the management largely will be the use of dynamic hip screws. And because the morbidity and mortality from untreated neck of femur fractures are really high. And because the morbidity and mortality are really high, it's important, therefore, to treat the fractures in such a way that they improve functionality, improve mobility, and this is done vis-a-vis the age of the patient, the comorbidities of the patient, and the skill of the surgeon. So again, we said that to the iliopsoas attaches to the lesser trochanter, and the psoas has a deep part which originates from the transverse process of L1 and L1 to L4, and the superficial part which originates from the vertebral body and the intervening intervertebral disc of T12 to L4. These muscles together help to flex and externally rotate the hip. The greater trochanter receives the insertion of the gluteus medius and the minimus, and they arise from the iliac bone. And later we would see that these muscles are responsible for giving stability to the pelvis, okay, during walking and during standing. So we talked about arthroplasty under the when we spoke about the fracture of the neck of femur and the possible surgical options. We said that type 1 and type 2 will require dynamic hip screw, and type 3 and type 4 will require arthroplasty. And so, therefore, it's important to have an idea of what the surgical approaches, what are the surgical approaches to the hip? What are the surgical approaches to the hip? So the surgical approach to the hip, okay, is the anterior approach, which is called the Smith-Patterson's approach, the anterolateral approach, which is the Watson-Jones approach, the lateral approach, which is the Hardinge approach, and the posterior approach, which is the Morse approach. Again, we spoke about the gluteus medius and the gluteus minimus, and we said that the gluteus medius and the gluteus minimus attaches to the greater trochanter. Now, the gluteus medius and minimus is supplied by the superior gluteal nerve, which is L4, L5, S1. And this is responsible for abduction of the hip when standing and stabilizing of the contralateral pelvis when walking. So the important thing to note about this test is that it tests injury to the superior gluteal nerve. And so when the patient or when the individual has a feet off the ground, okay, when an individual has a feet off the ground, the contralateral gluteus medius and minimus raises the pelvis up on the side that the foot is off the ground. And so, which means that if the foot is off the ground and the pelvis on that side sags, the muscle with the problem is the muscle on the contralateral side, because it is the contralateral gluteus medius and minimus that is responsible for raising the pelvis and preventing a tilt or a droop of the pelvis on the opposite side. A good way to remember this is using the mnemonic, the sound side sags. So the sound side will sag. So the side, so the side of the muscle that is normal, okay, will sag. All right. So the side of the muscle that is normal will sag. So the ipsilateral side, okay, which is off the floor, will sag, because that side that is off the floor, the function of elevating the pelvis on that side is carried out by the contralateral gluteus medius and minimus slash the contralateral superior gluteal nerve, whose root values are L4, L5, and S1. The gluteus maximus, okay, is responsible for externally rotating the hip, and it is supplied by the inferior gluteal nerve. We talked about the lateral rotator of the hips, and we said that the lateral rotator of the hip was inserted into the intertrochanteric fossa, and this, we said this was the piriformis superior inferior gemellus, obturator internus externus, and the quadrator femoris. Now, it's important for you to be able to identify the linear aspera, the posterior aspect of the femur. It's also important for you to know what the function of the iliotibial tract is. And the iliotibial tract is a condensation of the fascia lata, okay? And this iliotibial tract gives attachment to both the gluteus maximus, which is supplied by the inferior gluteal nerve, and the tensor fascia lata, which is supplied by the superior gluteal nerve. The iliotibial tract itself is supplied by the inferior gluteal nerve, and it runs from the iliac tubercle to the Gerdy's tubercle. And this tract helps to stabilize the knee in extension and partial flexion. So therefore, it is important when a patient or an individual is running and walking. Next is, what is the, so we talk about the sciatic nerve, and we want to know what is the surface marking of the sciatic nerve. So the surface marking of the sciatic nerve sorry. All right. So okay. So the surface marking of the sciatic nerve. So if this is the anterior superior iliac spine. Okay, let's make this a little bit more. Okay, so okay, So if this is the all right, so if we assume that this is the posterior superior iliac spine, this is the ischial tuberosity, and this is the greater trochanter. So the surface marking of the sciatic nerve will be midway between the posterior superior iliac spine and the ischial tuberosity. So we take a point midway between the posterior superior iliac spine and the ischial tuberosity, and we take another point midway between the ischial tuberosity and the greater trochanter, and then we draw a curved line. Okay, this curved line will correspond to the surface marking of the sciatic nerve. And the sciatic nerve will run underneath the gluteus maximus and run infralaterally, lying midway between the ischial tuberosity and the greater trochanter as it enters the posterior thigh. In the posterior thigh, if you're looking at the patient from the front, it runs behind the adductor magnus, okay, and anterior to the long head of the biceps. There are different variations of the sciatic nerve, okay, and one of these variations is that it can enter the gluteal region and separate split into its components, the tibial nerve and the common peroneal nerve, and with the tibial nerve passing below the piriformis and the common peroneal nerve piercing it, or the tibial nerve can exit below the piriformis and the common peroneal nerve exit from above the piriformis. Okay, there are several other variations of the anatomic variation of the sciatic nerve. Then we turn our attention to the compartment of the thigh, and the thigh is divided into, the thigh has three compartments. All right, the thigh has three compartments, and these compartments are the anterior compartment, the medial compartment, and the posterior compartment. Each of these compartments has its specific muscle group, the nerve, and the action it performs. Okay? In general, so the anterior compartment essentially is composed of the sartorius muscle and the quadriceps femoris. The quadriceps femoris is divided into four. It has the rectus femoris, which has a straight head and a reflected head. Okay? And then it has the vasti, which has the vasti medialis, intermedius, and the lateralis. The rectus femoris, again, has two heads, okay? The straight head and the reflected head. So this arises, okay, from the anterior inferior iliac spine, all right, and the external surface of the bony ridge that forms the groove on the iliac portion of the acetabulum, all right? So, and of course, the nerve supply is the femoral nerve. So, again, to summarize, the anterior compartment has the sartorius, quadriceps femoris, The nerve of the anterior compartment is the femoral nerve, and the action with the root value L2 to L4, and the action is to extend the knee, okay? Extend the knee, and because the straight head of the rectus and the sartorius crosses the hip joint, the straight head of the rectus femoris and the sartorius can also flex the hip. We turn our attention to the medial compartment, which it comprises of the gracilis, the pectineus, and the adductors. The adductors, we have the adductor magnus, the adductor longus, and the adductor brevis. And the muscle, again, and the nerve supplying this compartment is the obturator nerve, L2 to L4, except for the pectineus, which is supplied by the femoral nerve, and part of the adductor magnus, which is supplied by the sciatic nerve. And the function of the medial compartment is adduction of the hip. Then we turn our attention to the hamstrings, the posterior compartment, and the muscle of the posterior compartment is the hamstring. Is the hamstring muscles. And of note is that the hamstring is made up of, the hamstrings are made up of the medial and the lateral muscle group, okay, of the hamstring. The medial muscle groups are the semimembranosus and the semitendinosus, and the lateral muscle group is the biceps femoris, okay, the long head and the short head of the biceps femoris. Now, the exception in this group is the short head of the biceps femoris for two reasons. Number one, the short head of the biceps femoris originates from the femur, and it is innervated separately by the common peroneal nerve, root value L5 to S2. But generally, the posterior compartment receives its nerve supply from L4 to L, from the sciatic nerve, root value L4 to S3. And it helps to flex the knee. This compartment will flex the knee and will extend the hip joint if it crosses the hip joint. If the muscles that cross the hip joint in this compartment will extend the hip. So we talk about the femoral sheath, and the femoral sheath is a funnel-shaped sheath about 3 to 4 centimeters long, found that encloses the superior aspect of the femoral vessels, and medial to these vessels is the femoral canal. Okay. And this femoral canal that is found medial to the vessel helps for expansion of the femoral vein. And during repair of femoral hernia, if it is narrowed too much, it can prevent tightening up the space available for expansion of the femoral vein and cause deep venous thrombosis. It's important to know that the femoral nerve does lie outside the sheath, and the femoral sheath is divided into compartments by septums, okay? And these septums separate the femoral artery. So you have the femoral nerve more laterally, then the femoral artery, which is separated from the femoral vein, and the femoral vein is separated from the femoral canal. Okay, and within the femoral canal is the lymph node of Cloquet and fat. The femoral ring is the entry into the femoral canal, And the ring is bounded posteriorly by the superior ramus of the pubis and the pectineal ligament, anteriorly by the medial part of the inguinal ligament, and medially by the lacunar ligament. And then laterally by the femoral vein and its dividing septum. Because remember, we said that the femoral canal is separated from the femoral vein by its own septum. And we will see that here. So as you can see, this is the femoral ring, okay, which is the entrance into the femoral canal. And you can see that this is the lacunar ligament, okay? This is the lacunar ligament forming the medial aspect of the femoral ring. And the posterior aspect of this ring is formed by the pectineal ligament, okay? Or the superior ramus of the pubis. And anteriorly by the inguinal ligament. Okay, so, and then this is the femoral vein, this is the femoral artery, and you can see here that this forms the sheath. Okay, all right. Now, there is also a concept. Again, I want you to take your attention to the lateral femoral cutaneous nerve, okay, just arising beneath the inguinal ligament at the lateral aspect, okay. This lateral femoral cutaneous nerve can be compressed there and cause an entrapment syndrome, okay, called myalgia paresthetica, okay, called myalgia paresthetica. And this nerve, you can see, it has its relationship to the anterior superior iliac spine. Okay, so if you look here, there is a concept called the muscular lacuna and the vascular lacuna. And the muscular lacuna is just if you notice right here, you have a sheet, okay? Yeah. So right here, you have a sheet, all right, that divides the vascular lacuna from the muscular lacuna, okay? So if you just looking at the diagram, therefore, you can therefore tell me that the contents of the muscular lacuna is the femoral ring or the femoral canal, which will contain the deep inguinal nodes, the femoral vein, the femoral artery. And again, you can see within, this is what I want you to see here. You can see here, colored yellow within the circle, that is the femoral branch of the genital femoral nerve. So these are the contents of the vascular lacuna. Again, what about the muscular lacuna? So the muscular lacuna, the content will be the femoral nerve. Okay, remember that this is the dividing sheet. Okay, so the femoral nerve, okay, the femoral nerve, the iliacus muscle, the psoas major muscle, combined together, we can say the iliopsoas, all right, and this little fellow here, the lateral femoral cutaneous nerve, which compression there will cause mononeuropathy of the lateral femoral cutaneous nerve. So, having said that, we turn our attention to the femoral triangle and the Hunter's canal, or otherwise called the adductor canal. So the femoral triangle, all right, is bounded so I'm going to do this. All right. So the femoral triangle is bounded superiorly or at the base by the inguinal ligament, medially by the medial border of the adductor longus, and laterally by the medial border of the sartorius muscle. The floor comprises of the pectineus muscle, comprises of the pectineus muscle and the adductor part of the pectineus muscle, and laterally you have the iliopsoas. So the floor is made up of the iliopsoas laterally and the pectineus muscle medially. And it contains the femoral nerve artery, which is found at the mid-inguinal point, which is the point, the midway between the anterior superior iliac spine and the pubic symphysis. And this is different from the midpoint of the inguinal ligament, which is between the anterior superior iliac spine, midway between the anterior superior iliac spine and the pubic tubercle. Okay, so the adductor canal, the adductor canal is also called the subsartorial canal. And this canal runs from the apex, of the femoral. So if we take, so what is the surface marking of this canal? So the surface marking is 2/3 of the way between the anterior superior iliac spine and the adductor tubercle of the femur, 2/3 of the way. So if we divide this into 3, 1, 2, 3, all right, you find out that 2/3 of the way, so this is 1/3, 1/3, 1/3. So 2/3 of the way, between the anterior superior iliac spine and the adductor tubercle proximally, that point will give you the beginning of the Hunter's canal. And the Hunter's canal runs from the apex of the femoral triangle and into the popliteal fossa, all right, and into the popliteal fossa. Now, the boundaries will be anterolaterally by the vastus medialis, anteromedially by the sartorius, which also forms the roof, and posteriorly by the adductor magnus. And it contains the femoral artery, the femoral vein, the saphenous nerve, and the nerve to the vastus medialis. We'll then turn our attention to the knee joint. So the patella gives the attachment to the quadriceps femoris tendon and attaches the quadriceps femoris to the tibial tuberosity via the patellar ligament. The function of the patella is to increase the power of the quadriceps by increasing the leverage of the tendon, and therefore, by increasing the leverage this tendon can have or exert on the femur, it does so by increasing the angle, okay? So, sort of like a lever, all right, to adjust the force that the quadriceps femoris tendon can exert on the knee and the leg, okay? And then it protects the anterior aspects of the knee joint. Of course, it is protected from dislocation by fibers of the vatus medialis and the lateral femoral and the prominence of the lateral femoral condyle. There are important ligaments around the knee joints, and it's important to remember these ligaments. And part of the OSCE, the examination aspect, will be knowing how to test for these ligaments, see if there's injury to the anterior cruciate, posterior cruciate, the lateral collateral, or the medial collateral ligament. Here, just to give you a rough idea, so the anterior cruciate ligament attaches to is originating from the tibia, okay? So from the anterior portion of the tibia, the anterior cruciate ligament originates from there and inserts into the intercondylar notch, okay? Or the lateral condyle, all right, of the femur. The posterior cruciate arises from the posterior aspect of the tibia and attaches itself to the medial condyle of the medial condylar aspects of the intercondylar notch. The posterior cruciate is the strongest of the two cruciates. All right, so it's an important fact for you to bear in mind. What is the unhappy triad? So the unhappy triad is a triad of injury to the cruciate ligament, the medial collateral, so injury to the anterior cruciate ligament, the medial collateral ligament, and medial meniscal tear. And this will happen during sports when there's injury or blunt force to the lateral aspect of the knee joint. Okay, and an important fact that you should bear in mind is that the gracilis and the semitendinosus tendon can be harvested for reconstruction of the anterior cruciate ligament. The knee receives its innervation and its blood supply from the femoral nerve, tibial nerve, and common peroneal nerve, and its blood supply from the femoral, popliteal, and anterior tibial artery. The leg again is divided into compartments. The leg again is divided into compartments. And one important clinical correlation here is that there is, during fracture of the bones of the leg, vis tibia fibula, the patient can have what is called compartment syndrome. And a way to know that this patient, so how do you know that this patient has compartment syndrome? So compartment syndrome, the first thing you should know is that compartment syndrome is an orthopedic emergency, and everyone should be able to recognize a compartment syndrome. And it presents with pain that is out of proportion to the injury sustained. So in someone who has a swollen leg and the patient is complaining of excessive pain on passive stretching of the ankle, then you know that this patient might have compartment syndrome. So pain that is out of proportion with the injury sustained. Now, I know there is the whole 6 Ps, paresthesia, pulselessness, poikilothermia, pain, blah, blah, blah. It's important for you to recognize that pulselessness, paresthesia, paralysis, pain, poikilothermia are all late signs. And by the time you're seeing these signs, things may already be far gone. In other words, the muscles may be facing impending necrosis. So it's important to keep this in mind. Yeah, so now we talk about the compartment of the leg. The leg is divided into the anterior compartment, the lateral compartment, and the posterior compartment. The anterior compartment is so the leg is divided into the anterior compartment, the lateral compartment, and the posterior compartment. The posterior compartment is further divided into the superficial compartment and the deep compartment. Each of these compartments has its own peculiar innervation, vessel, and action. Okay, so that's the way I want you to remember this. So each compartment has muscle, nerve, vessel, action. Okay, the anterior compartment comprises of the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and the peroneus tertius. And the nerve of this compartment is the deep peroneal nerve. The vessel of this compartment is the anterior tibial vessel, and this muscle together helps in dorsiflexion. In addition to dorsiflexion, the tibialis anterior inverts the foot. Okay, the tibialis anterior inverts the foot. Then we have the lateral compartment, which comprises of the peroneus longus and brevis, and it is supplied by the superficial peroneal nerve, right? It's supplied by the superficial peroneal nerve. And the function of the peroneus longus and brevis is to aid eversion at the subtalar joint. Okay, so the anterior compartment and the lateral compartment are separated by the anterior intermuscular septum. Okay, while the lateral compartment and the posterior compartment is separated by the posterior intermuscular septum. The posterior compartment is separated from the anterior compartment by the interosseous membrane. Okay, good. We said that the posterior compartment was subdivided into superficial compartment and the deep compartment. And the superficial compartment is separated from the deep compartment by the transverse intermuscular septum. The superficial compartment is made up of the soleus, gastrocnemius, and the plantaris, and the deep compartment is made up of the popliteus, tibialis posterior, flexor hallucis longus, and flexor digitorum longus. The posterior compartment is the nerve supply of the posterior compartment is the tibial nerve and the posterior tibial nerve. Okay. There are no vessels in the superficial compartment. However, in the deep compartment, the vessels are the peroneal vessels and the posterior tibial vessels. And the function of the superficial and deep compartment is to plantar flex the foot at the ankle joints. The popliteus, which is part of the deep compartment, helps to unlock the knee. And the posterior tibialis together with the anterior, with the tibialis anterior or the anterior tibial muscle and the posterior tibial muscle, both helps to invert the foot at the subtalar joint. So, in summary, I would say that the first thing to know, right? The first thing to know is that when we talk about the compartment of the leg, you need to know the muscles, the nerve, the blood supply, and the actions. So the movement, so if I say dorsiflexion, what helps in ankle dorsiflexion? Yeah, what's the muscles? The muscle group that helps in, so that's the anterior. So that's the anterior compartment, tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus tertius. We help in ankle dorsiflexion. Okay, and we said that this is supplied by the deep peroneal nerve. Okay, the deep peroneal nerve. And then we also, and so the ankle dorsiflexion is occurring at the ankle joint, okay, between the tibia, fibula, and the talus. Now, when we talk about plantar flexion, we said plantar flexion was observed by the muscles of the posterior compartment, okay? And we listed those muscles out. And we also said that inversion was by the, what helped in so inversion was by the lateral compartment, peroneus longus, peroneus brevis, helps with inversion at the subtalar joint. And while inversion was observed by the tibialis anterior and the tibialis posterior. Now, both inversion and eversion occurs at the level of the subtalar joint. Again, the common peroneal nerve can easily be injured, and injury to the common peroneal nerve means that there is loss of dorsiflexion and also loss of, so if there's injury to the common peroneal nerve, we divide into superficial peroneal nerve and deep peroneal nerve. And we said that the superficial peroneal nerve supplied the lateral compartment, which was responsible for eversion, and the deep peroneal nerve supplied the anterior compartment, which was responsible for dorsiflexion. Therefore, it means that the patient who has a common peroneal nerve injury, we lose dorsiflexion and we lose eversion at the subtalar joint. And loss of dorsiflexion and eversion will leave plantar flexion and inversion will leave plantar flexion and eversion and inversion, which is now subserved by the posterior compartment muscle. And remember that the tibialis posterior is a muscle that's found in the posterior compartment of the leg. And so this will result in foot drop. Okay, and then also there will be loss of sensation in the dorsum of the foot. All right, so the ankle joint. Ankle joint is, well, not a lot of people's favorite topic, really, the ankle and the foot. I mean, if we're to be honest, but the whole idea is to guide you and to help you understand the ankle joint. So you must be able to identify the following bones: the calcaneus, the sustentacular tali, the talus, the navicular bone, okay, the cuboids. And then you must be able to identify the medial cuneiform, intermediate cuneiform, and the lateral cuneiform, okay? And we have said that identification of the foot bones is important, okay? And then again, you must be able to articulate the tibia and the fibula together in the correct way. And to do that, you need to identify the tibial tuberosity, you need to identify the head of the fibula, and then articulate the head of the fibula with its with the lateral condyle of the tibia, and there you have it. And then you know that the styloid process, you then know that the styloid process of the tibia and fibula will be inferior, okay? And so to orient anterior, you need to look for the tibial tuberosity. Okay, so just by the wayside. So there are certain ligaments and joints that you have to bear in mind. The talofibular joint, which is a the tibiofibular joint, which is a syndesmosis. And then the ankle joint itself, it's a synovial hinge joint, and this is formed by articulation of the tibia, fibula, and the trochlear surface of the talus. The mid-tarsal joint, or the short part joint, is the calcaneocuboid joint and the talonavicular joint. And then you have the subtalar joint, which is the talocalcaneal joint, all right, which is the plane in which you have the inversion and eversion occurring. The important ligaments to remember is the deltoid ligament, okay, which is attached to the medial malleolus, sustentacular tali, naviculum, and spring ligament. And then the spring ligament, and this is medial. And then the spring ligament, which is and then the spring ligament, which also I'd say is another important ligament, and this is the plantar calcaneonavicular ligament. Okay, you also have other ligaments such as the posterior tibiofibular ligament, the posterior talofibular ligament, which you also have to know because these are responsible for providing stability to the ankle joints, and sometimes ankle injuries can be difficult to treat. The foot, again, the foot has its arches and its muscle layers, okay? And the muscle layers, so it has 4 muscle layers, okay? From superficial to deep, so you have the abductor digiti minimi, abductor hallucis, and flexor digitorum brevis. In the second layer, you have so going deeper now, you have the tendon of the flexor digitorum longus, the flexor hallucis longus, and the quadratus plantae, and the 4 lumbricals. In the third layer, you have the flexor hallucis brevis, flexor digiti minimi brevis, and the adductor hallucis. And then the 4th layer, which is the deepest layer, will have the interossei and the tendon of the peroneus longus and the anterior and the tibialis anterior. The arterial supply to the foot is from the continuation of, so it's from the dorsalis pedis artery, which is a continuation of the dorsalis pedis artery, and which is a continuation of the fibula, the anterior tibial artery. So the arteries to the foot is the dorsalis pedis artery, and it's a continuation of the anterior tibial artery. And don't forget that the anterior tibial artery, so you have the popliteal artery, okay? The popliteal artery will divide into the fibular artery, okay? So because this is also another important thing that you have to know, so I'm going to go back a few steps. So the popliteal artery will divide into the anterior tibial artery, okay? So the popliteal artery divides into the anterior tibial artery, which comes off to the front. And this is all posteriorly now, because don't forget that the blood supply, the entire blood supply, is coming from the femoral artery, then into the adductor canal, then into the popliteal fossa. Then in the popliteal fossa, it divides into, because the whole supply, blood supply of the lower limb is from the common femoral artery. And so at the level of the popliteal artery, the popliteal artery divides into the anterior tibial artery and into the tibioperoneal trunk, okay? So I give you a sketch here. So if this is the popliteal artery, okay, the popliteal artery will divide into the anterior tibial artery, okay, and continue down as the tibioperoneal trunk. Okay. The tibioperoneal trunk will now further divide. The tibioperoneal trunk will further divide into A, posterior tibial artery, B, peroneal artery. Okay. The posterior tibial artery is longer because the posterior tibial artery is going to go down into the foot, divides into the medial and the lateral plantar artery. So this is in the foot, okay, in the plantar surface. All right. While the peroneal artery, all right, will just be there. Okay. So this is the distribution of how the popliteal artery divides to supply the leg and the foot. So I had to come there because of the to talk about the dorsalis pedis artery, because the dorsalis pedis artery is a continuation of the anterior tibial artery, and it does so once it crosses the ankle joint. Okay, so once the anterior tibial artery crosses the ankle joint, it is now called the dorsalis pedis artery, and it is easy to palpate the dorsalis pedis artery, which you should be able to palpate just lateral to the extensor hallucis tendon, okay, which you should be able to palpate just lateral to the extensor hallucis tendon. Now, once it enters, okay, once it crosses the ankle joint and becomes the dorsalis pedis artery, okay, you find out that the dorsalis pedis artery continues anteriorly over the dorsal aspect of the talus, the navicular bone. All right, remember that the talus, the navicular, the medial, intermediate, and lateral cuneiform are somewhat-ish more medial. Okay, so it runs on the dorsal surface of the talus and the navicular bone and the intermediate cuneiform. Okay, and then it then passes downwards, all right, and goes into the plantar aspect of the foot where it joins the deep plantar arteries to form the plantar arch of the foot. So this is the, and then of course the posterior tibial artery continues and divides at the medial and the lateral plantar artery, and the medial and the lateral plantar artery will then give blood supply to the sole of the foot. So again, it's also important to know. So if I say, so what are the structures you can find behind the medial malleolus? Okay, what are the structures behind the medial malleolus? And so a very way to remember this is Tom, Dick, and Very Naughty Harry. Okay, Tom, Dick, and Very Naughty Harry. And Tom there refers to the tendon of the tibialis posterior tendon, the tendon of the flexor digitorum longus, and the posterior tibial. So you have Tom, which is the tendon of the tibialis posterior. You have Dick, which is the tendon of the flexor digitorum longus, and Very, which are the tibial vessels. Naughty is the tibial nerve, and Harry will be the flexor hallucis longus. So Tom, Dick, and Very, Naughty, Harry. Good. So yeah, so then we will conclude this session by talking about the arches of the foot. So what is it about the arches of the foot? So the arches of the foot, what I need you to remember about the arches of the foot is that each arch of the foot has a bony component, muscular component, and ligamentous component. So there is the bony component, the muscular component, and the ligamentous component. So if we consider the medial longitudinal arch, okay, the bony component of medial longitudinal arch will be the calcaneum, the talus, the navicular, the three cuneiforms, the first three metatarsals. Okay, the ligaments will be the short, long plantar ligaments and the spring ligaments, and the muscles will be the flexor hallucis longus, the peroneus longus, tibialis anterior and posterior. Again, we move our attention to the lateral longitudinal arch. Again, the lateral longitudinal arch has the bony component, the muscular component, and the ligamentous component. And the bony component will be, of course, again, the cuneiform, the talus, the calcaneum, pardon me, the calcaneum, the cuboid, all right, and the lateral two metatarsals, all right. The ligaments here will remain the same as the long and the short plantar ligaments. And the muscles will be the peroneus longus, brevis, and the short plantar muscles. Then we have the transverse arch, all right, which essentially is the base of the 5 metatarsals. Okay, this doesn't have a ligamentous component. Okay, so the transverse arch. So if I say here the transverse arch, all right, the base of 5 metatarsals, no ligaments, and the muscle component here is the peroneus. Okay, so this therefore will conclude this segment. Thank you very much for joining us today. We look forward to seeing you in our course. This is MRCS Strategies.